on a nice vacation.
Okay, I think we need to address, give a couple of minutes to me on anti-pro-BNP. There are many issues, whether patient can afford in general population or not. All these issues are understandable. But as I said, India is a different country, and every patient pays for all his treatment. Now, at our hospital, I have made it a policy because I always face one simple challenge, that there is such an existing data of science. Is there a scope to my management to this single patient? I am not concerned about population in general, but every patient coming to my hospital, to me, what can I do better for this patient? And we are learning over a period of time that understanding anti-pro-BNP value of the patient at the time of bedside admission makes a lot of sense, not only to risk stratify for long term, but deciding right time to do angiography. You can end up in trouble with angiography even in these patients if anti-pro-BNP levels are too high. So it allows me sometimes to defer the angiography as well. So I think patient management can improve if you look at only one patient. It may not add statistical value to the public, it cannot add statistical value to the study. But finally, we have to say everything cannot be statistically driven. Something has to be clinically driven.
One of the studies that we reported previously was the A to Z study, and that looked at the NT-proBNP on discharge and at follow-up. And in those where it was either up at discharge and remained up, had the worst prognosis.
Right.
Those where it was up and came down had a better prognosis. So I don't disagree on discharge, but as far as the acute management is concerned, I wouldn't use it to guide my acute management.
Okay.
Just a point to make, Madhika. See, in the presence of a pre-renal dysfunction, in fact, the value and the sensitivity and the specificity of the biomarkers significantly are affected when you see the values of creatinine in this patient. Primarily because, as we all know, that these biomarkers can be falsely elevated in the presence of renal dysfunction. So we have to keep that in mind when we interpret these results.
Okay.
But even then, if the values are so high, then the renal dysfunction doesn't come into it. If you only have borderline changes in the N-terminal pro-BNP or BNP, that is when the function comes in. Values more than 2000 as in this patient, then at that particular point, we would go more in favor of this.
I think we will leave anti-pro-BNP. It's a very interesting area, and yesterday when on the discussing with you, we have a lot of knowledge, but time has come to understand there are gaps in knowledge. With you, gaps in knowledge on anti-pro-BNP management of acute heart failure. Give me a few more minutes.
Madhikar, one just
yes.
small key. I had a patient, PAMI done 1 hour after onset of pain. Patient did extremely well. 2 weeks later, he went to Madhikar's hospital, got a anti-pro-BNP done, which was very high. Patient is absolutely fine. What does it mean? Ejection fraction is around 40%.
In fact, it may well mean that this is a impaired ventricular function with systolic function, or sustained systolic function. So NT-proBNP is a sensitive marker of wall stress, and it may well be something else has precipitated that wall stress.
Yeah, I think you have raised a very important issue. There is a study called Which Early Therapy for Early Escalation MI in Acute Myocardial Infarction, which has shown that patients who undergo angioplasty have higher values of anti-proBNP at the time of discharge as compared to patients undergo thrombolysis. Probably in the early phase of acute MI, when you do angioplasty, little bit more myocardial damage because of the fragmentation of thrombi getting blocked into smaller vessels, and they have, by definition, incidence of LV at the time of discharge in hospital as compared to those who have not undergone angioplasty. So I think anti-pro-BNP adds tremendous value. We are learning about it in course of time.
How many people are doing anti-pro-BNP on a regular basis when the patient of this nature comes to their clinic? Can you raise your hands? So only 2 reach, and Madhikar is the 3rd reach.
No, I think because we are discussing too much, you must know anti-pro-BNP measurement is not easy. It needs very sophisticated equipment in your hospital to measure rightly.
We have a test which actually takes all the 4 measurements together. For example, we get myoglobin, we get CKMB, we get TROP-I or TROP-T, and we get BNP. In the same test for the same price as a
point of care assay.
So it's not expensive. So our patient gets it regularly because it's part of the we call it the cardiac profile in one hospital, we call it the cardiac triage in another hospital. But that happens, and it's the same pricing.
Okay.
So basically, our patient gets it not because of the fact that we ask for the NT-proBNP, we get a BNP on the admission of the patient. And we do this basically in an unstable angina kind of situation like this, where maybe it's an infarct which you are looking for, you don't have a clear ST segment elevation out over here.
Okay.
So this is the richest guy.
So no, it's not a question of, it's a question that it's quite cheap actually, because it contains all these 4 markers together.
This is a very interesting discussion now. It means actually that we get things we don't ask for, and the reason to take a sample or do anything with a patient is that I have a directed suspicion of something and I want to have that illustrated. It's very dangerous to take too many samples because 5% of them will definitely, by definition, be aberrant, and then you have to start another investigation to see whether that was true or not. And I have lived through that. We had an ingenious chemist in Sweden who invented something that analyzed everything at the same time at a reasonable price. And that was sold to a number of district physicians around the hospital where I lived. And we got a constant stream of transferal notes with people with abnormal values, which we have to investigate at a high price, just because they have been taken samples that were not necessary and there were no clinical indication for the sample. So I think that we should try to use our common sense and not take too many things or do things that we don't have intellectual background to. We may actually be fooled by the technology instead of using the technology to improve our own clinical judgment and intelligence and knowledge.
Okay. I think we'll move on from here to further discuss. Next slide, please. Now you look at now.
I think before this, there's a very good point on the ECG, which we need to look at. The ECG shows.
Can you go back on the slide? Show the ECG, please.
Can you go back to this?
The ECG shows an elevation in lead AVR. Nobody concentrates on lead AVR.
Left main type of
it's a very important lead to look. It's called the orphan lead very often because you just leave it alone. Most of you describe V4, V5, V6. Nobody concentrates on V1 and AVR. That's a global ischemic pattern that you're looking at over. And it's a pattern which you must always look at, because if you have 2 millimeter or a 1 millimeter elevation in lead AVR, it suggests that you have significant global ischemia. And ischemia tells you that you're either dealing with a triple vessel, a very proximal circumflex.
With type 2 diabetes.